that is what happens for somebody who has diabetes. Sometimes people refer to it as sugar diabetes. That is because there's another form of diabetes that in the medical world we also know. So this sugar diabetes, or the one that related to sugar, is usually referred to as diabetes mellitus. And there's another one also called diabetes insipidus. So those are two different conditions. The insipidus has no relation with the mellitus. The insipidus just has to do with the kidney's inability to concentrate urine. So the reason why they share the name is because of the symptoms that will occur. Both of them will cause patients to urinate a lot, but their causes are very different. And the insipidus is quite rare in our population. So that's what I can say about diabetes.
Thank you so much, Dr. Akpalu. So next we will go to Dr. Anand. Dr. Akpalu has kind of told us what diabetes is, and kind of separated diabetes mellitus from diabetes insipidus. So it looks like we are talking about diabetes mellitus, that's sugar diabetes. Are there different types of diabetes as we are discussing? And if so, what are they?
Thanks, Professor Jonathan. Yes, so there are different types of diabetes mellitus. The common ones being type 1 and type 2 diabetes. So I'll explain the type 1 first, and then go to the type 2. And then I'll also talk about gestational diabetes, which affects women that are pregnant. So with type 1 diabetes, it's diabetes that is caused by a lack of insulin producing cells. So what happens is your body attacks the cells that produce insulin in your pancreas. It's called an autoimmune response or an autoimmune disease. So basically what happens is the cells, the fighter cells in your body, the T cells, go and fight the beta cells, which are the insulin producing cells in your pancreas. And so that results in you not being able to produce any insulin. And because you don't have an insulin, you get a buildup of sugar and hence, diabetes. Type 1 diabetes is commonly found in younger age groups. So you find that it's a diabetes that's diagnosed in probably from childhood, early teens, and probably early adulthood. And usually people who have type 1 diabetes are insulin dependent diabetics. So they never go on tablets, only use insulin. There's also a genetic component that is also associated with type 1 diabetes. And also type 1 diabetes can also come about when the pancreas is also attacked, by some other, condition, like say, for example, some other kind of disease that destroys the beta cells. You can also end up having what is called type 1 diabetes. So for example, if someone has pancreatic cancer or something, with the beta cells, they can end up having what we call type 1 diabetes. Type 2 diabetes, on the other hand, is diabetes that is caused by the resistance of cells responding to the insulin. So this is diabetes whereby the person is actually producing the insulin that is required to regulate the sugar. But for some reason, the cells that are supposed to be responding to that insulin are not working properly. This kind of diabetes is common in older age groups. So it's known as a disease that, kind of comes about for people who are middle-aged, going up, as you're getting older. Though having said that, research is showing that nowadays, even children are getting it. And that's primarily because type 2 diabetes is associated to lifestyle, factors, such as obesity, for example. Type 2 diabetes is usually diabetes that is diagnosed, later on and in life, and mostly people who are type 2 diabetics are usually on medication, which is like tablet form, so they don't take insulin. In terms of the gestational diabetes, so that comes about when a woman is pregnant. So you find that it is only when she's pregnant that she's actually diabetic. Some women can, continue to be diabetic even after pregnancy, but for a lot of women after pregnancy, the diabetes sort of goes away, and it's been linked to the hormones that are produced in pregnancy. So from your placenta, those hormones can actually make your pancreas a bit insensitive to the insulin that's being produced, hence why you become diabetic. And usually women in their pregnancy, so if you've got high risk factors such as probably your, more overweight than usual, you gain a lot of weight during pregnancy, you find that your doctor would offer you a test which is called a GTT, or a glucose tolerance test. And it's when you have that test done that the diagnosis of diabetes is discovered or is found. And for women that have had that kind of test, you're usually offered that test between the weeks of 24 weeks and 28 weeks. And that's when, you know whether you've got diabetes or you don't, gestational diabetes. And then you're monitored throughout the pregnancy to make sure that, your blood sugars are properly controlled. And after you give birth, you're also monitored, and hopefully it will resolve. If not, you might have to actually go on to being managed, as a type 2 diabetic. So those are the three main types of diabetes that I'll talk about now. Thank you.
Thank you very much, Dr. Anand. Do you want to say something a little bit about like pre-diabetes? Some people kind of will say that they are pre-diabetic. I mean, what is that? Is that a thing?
So yeah, so pre-diabetes, what it basically means is that you are at risk of developing diabetes, but you're not actually there. So when you have the glucose, say for example, if you're going to have your bloods taken to check, the sugar levels in your blood, it may be that your blood readings are actually showing some levels that are high, not high enough for you to be called diabetic, but are high enough to show that there's a risk of you becoming diabetic. So that is what is termed pre-diabetic. That can also be discovered even during pregnancy, where women do the GTT. Your physician may actually tell you that, oh, actually, you know what? We've done your GTT. You're not diabetic, so we're not going to treat you. But it did show that you're pre-diabetic, so you need to be a bit more careful or aware of the fact that if you don't make some certain changes in your lifestyle, you can actually end up becoming diabetic.
Thank you so much. So our next question is for Dr. Che. How common is diabetes in our societies? I mean, is it just at the West, the rich? How common is it? Can you discuss that? Thank you.
Okay, thank you very much. So to talk about diabetes, I know we used to think it is just a disease that belongs to a particular group of people. That is not the case anymore, and it has been so for the past probably 20 years. So if we refer to the current estimate from the International Diabetes Federation, in 2019 alone, we had almost 500 million people living with diabetes worldwide. Let me break it down. 500 million doesn't come out clearly. Almost 500 million people were living with diabetes. And this number is even projected to increase up to over 500 million, 578, and to 700 million by 2045 if we continue business as usual. And as Dr. Anand just told us, most of these diabetic cases that were discovered are people with a type 2 diabetes. So type 2 diabetes forms about 90% of the diabetic cases that we have. And what is sad is that in 1 out of 2 of the people living with diabetes do not even know that they have diabetes. So almost 232 million people in 2019 alone are diabetic, but they are unaware that they have the disease. And as you said, the disease occurs both among the young, as we heard from Dr. Anand, the young, the old. It does affect the rich, the poor. It occurs both in urban areas, in rural areas, in high-income settings, and in low-income countries as well. Although if we look into details, it is not the same. For example, when you are older than 65 years, then so at least 1 in 5 people older than 65 years had diabetes. So in 2019 alone. And if we look at these figures and compare to what we have now, we know corona is a horrible disease. Yeah, and since 2019 to now, I just checked the current state, and we have 152 million cases of corona since 2019 to now. So if you compare it to the over 463 million cases of diabetes in 2019 alone, it gives you a sense of how common this disease is and how important it is. And what is also sad is that 79% of these half a billion people with diabetes were living in low and middle income countries. All right, so it is not a disease only of the West. And out of this 463 million people that had the diabetes caused 4.2 million deaths in 2019 alone. So this is way over what corona has done. Corona has killed almost 3.2 million people. So from 2019 up to now, diabetes in 2019 alone took away 4.2 million people. And if we want some other figures on type 1 diabetes, we also have over 1 million children and adolescents living with type 1 diabetes all over the world. And as Dr. Anand just told us about diabetes in pregnancy or gestational diabetes, it is also found in 2019 that 20 million live births, that is 1 out of every 6 live births, was affected by diabetes during pregnancy. So this gives you a good picture of what diabetes looks like in the world. And for the pre-diabetes, that is those who are on their way to where you don't want them to go to, we had almost 374 million people who are pre-diabetic in 2019 alone. So diabetes is a disease that cuts across. It is everywhere. If we want to look at it in terms of the world regions, or which country has the highest prevalence in 2019, if we standardize the age, that is all across all ages, then we have the Middle East and North Africa had the highest prevalence of 12%, over 12% of the population having diabetes. So the league table is followed then by the West Pacific. If you go towards Australia, Malaysia area, they are second in line, this region. Then Southeast Asia follows up. Then we come to North America and the Caribbeans, then South America, South and Central America, then Europe and Africa come number 6 and number 7. But that should not make us jubilate that it is not a problem in Africa. If we flip and go to the populations or the prevalence of pre-diabetes, that is those who are waiting to get diabetes, there you see that North America and the Caribbean top the list, and then we follow by the West Pacific, and then Africa moves to place the 3rd place on the league table, which means we qualify now. It means we are a continent waiting to explode into diabetes, so we don't have to get complacent at all. And it is a very critical disease which affects many organs, kills a lot, and costs a lot of money to the society, over 760 billion, and even not counting the cost to your families and the society. So this is in a nutshell what diabetes looks like, the burden of diabetes in our world today.
Thanks, Dr. Nick. Dr. Josephine, my next question comes to you. So how does one know that he or she has diabetes? Now, growing up, I remember I used to hear stories of some people peeing and having insects come to the wee. And there are also other things you hear that, oh, someone who drinks too much water is probably diabetic and the person wees a lot. So how does someone know that they have diabetes?
She's muted.
Oh, you're muted, Dr. Palu.
My apologies. Yeah. So I was saying that what you're saying, you're right. What you're saying, yes. But I would like to say that most of for some people, they may present with no symptoms at all. What we say asymptomatic, and this commonly happens in patients who have type 2 diabetes. So they may be walking around with diabetes, but may not be showing any symptom or any sign of the disease. The only way they will get to know they have it is if they go in for a medical checkup, like a routine medical checkup, or they go to a hospital for one reason and the doctor says that, let me screen you for diabetes. So it's very important that we try and know our status when it comes to diabetes, particularly if you are at high risk. We're talking about those later on. Then following from that, then we have those who would actually present or have experienced the symptoms of diabetes, what we say the classical symptoms of diabetes. And this is because of the high amount of glucose in their blood, they tend to urinate. The excess of it comes in their urine, and this comes along with lots of water. So then they urinate a lot, so large volumes and frequently. And this would mean that they're going to get dehydrated, so they become thirsty, and therefore they have to drink. So that's how the cycle is. So you're urinating a lot, you become thirsty, then you drink a lot of water. So those two are linked. Then we have those who experience, say they are eating a lot, and that could also be a symptom of diabetes. Then there could be weight loss, and this is particularly so in the type 1 diabetes, where they don't have the insulin, so they can come in as part of their problems. They may have weight loss. You can also have weight loss in type 2 diabetes. I mean, in those in whom after a while their insulin levels start to drop, they can also lose some weight. There are other signs and symptoms which reflect the onset of complications of diabetes. And so amongst them, sometimes you may complain of blurring of vision. They cannot see very clearly when the eye is affected, or sometimes just the mere high level of the blood glucose can affect the way
Dr. Palu, can I please
functions.
interrupt?
And so during the period
Dr.
when their
Palu,
sugar levels are high, they cannot see very well. When the levels normalize. Sorry?
Can we please mute ourselves? And because I can hear some feedbacks, and I think I've had some messages that we can hear this typing effect. So if we are not talking, could we please stay muted? Thank you. Go on, Dr. Palu. Thank you.
Sorry?
Oh, we've lost her. Okay, I'm sure she'll come back. I could hear this feedback, and someone just sent a message to say they could hear it as well. So if you're not talking, then maybe she stay muted. But I hope she comes back.
Okay, so maybe we can kind of try to fill in while she comes back. So Dr. Che, Dr. Palu was talking about how you know, or how someone would know that they have diabetes. Can you just summarize what she said and maybe, add something to it?
Okay, yeah, sure. So Dr. Palu was just telling us that for most of type 2 diabetics, they may not have any symptoms, or what we call asymptomatic. And the other classical symptoms of diabetes has to do with the stage of the disease. So in the very early stages, as she said, because you are peeing out a lot of sugar, and that goes with water, you end up urinating a lot, often at night, frequently, and that also leads to thirst. So you are always very thirsty, and then you lose weight when you are not trying to lose weight. Yeah, and tied up with that, you feel very hungry. And for those that progress to the complicated stages, you end up with blurred vision. When it affects your nervous system, you may end up with tingling sensations in your hands and in your feet. And you also realize that you end up getting a lot of infections than you usually get. And for those that also at the very late stages of the disease, you realize that when you get sores or wounds, they take forever to go away. These are all signs and symptoms that you may have some problems with how your body converts the food you eat or the glucose into energy, or in this case, diabetes. As she was saying, type 1 diabetics, because the symptoms start more suddenly, it occurs more quickly than type 2, and they may have other symptoms such as nausea, vomiting, and stomach pain. And Dr. Annan already told us that this usually starts when they are children or in their teen or young, but we know that it does also happen now even in the adult. Yeah, so those are the main symptoms or signs of diabetes. If I may add, so because we spoke also about gestational diabetes, let me say that for gestational diabetes, you usually don't have any symptoms. So it is always an incidental finding for women that attend antenatal clinic. Your doctor or your obstetrician may then do the screening test, which we'll speak about shortly, within 24 to 28 weeks of pregnancy, and then you may find this. Although you do not have any symptoms, it does have an impact on you later on and on your child. So it is an important thing to be screened for. Yeah.
Okay, so we'll move on. Whilst Dr. Akpalu tries to come back in. So, Dr. Nick, so what test, I mean, how do we diagnose that? So you've talked about how common it is. First of all, we talked about what it is, how common it is, the types of it, and then we talked about, you know, how people will know that they have diabetes. The question is, how do we diagnose it?
Okay, good, thank you. So, apart from these signs and symptoms, you will agree that other diseases may mimic some of the signs and symptoms that we said. So for us to know, you will need to get a blood sugar test to find out if you have either pre-diabetes, type 1 diabetes, type 2 diabetes, or gestational diabetes. What is good is that these tests are so simple and the results are usually available so quickly. So your doctor will take one or more of the following blood tests. Either you do starting from a random blood glucose test to fasting blood glucose to oral glucose tolerance test or to a glycated hemoglobin test. I'll speak shortly about what these tests are and what they do. But these are the three basic tests that they will do. If your doctor also thinks that you may have type 1 diabetes, depending on your peculiar case, he may also test for antibodies in your blood. So Dr. Annan already told us that type 1 is mainly thought of to be an autoimmune disease. That is where your body's immune system starts attacking itself mistakenly. So your doctor may perform some tests to test for antibodies, autoantibodies in your blood to see if it is type 1. It is more in type 1 than in type 2. You may also perform some urine tests to test for ketones, which are produced when your body starts using fat for energy. And this is also typically indicative of type 1 other than type 2. So to talk more about the basic three tests that we use for diagnosis, we have the glycated hemoglobin test. So for this test, your blood, it measures how your body has been using sugar or glucose over the past 2 to 3 months. And if you permit me, I would like to share a screen so that our viewers can see well. I like this info graph by the CDC, the US Centers for Disease Control, which will help us to see. They call it the road to is the screen sharing now? Not yet. Okay. Oh, it should be sharing. Right. Okay, so I'm having challenges sharing the screen, but basically it is to picture diabetes as traveling. Good. Now it is sharing. Good. So diabetes is like, see it as if you're on the road to diabetes. So green is normal. When you are amber, then you are pre-diabetes, you are getting ready to stop, and red is diabetes. So for the first test, the glycated hemoglobin test, if your values are below 5.7% or 5.7% or below, we say that you are normal, then you are okay. If it is between 5.7 to 6.4%, it indicates someone in danger, so pre-diabetes. And then if your values are above 6.5%, then we say that you have diabetes. For the next test, the fasting blood sugar test, there are many types of blood that we test, but here using plasma, we measure your blood sugar after an overnight fast. So that is, you should not have eaten in the morning before we do this test. This is just after you have fasted for about 6 to 8 hours. So here, where your fasting blood sugar is 99 milligram per deciliter, or for those of us who use the SI unit, around 5.4 millimoles or 5.5 millimoles per liter, we say that is normal. If your fasting blood glucose is between 100 to 125 milligrams or 5.5 to 6.9, then we say you are borderline, you are pre-diabetic. You don't have diabetes, but you are on your way. And if it is above 126 milligrams per deciliter or 7 millimole per liter, then we say that you have diabetes. Then for the glucose tolerance test, this measures your blood sugar before and after you drink a liquid that contains glucose. So you usually will fast overnight before the test, and then before we give you this drink, we draw some blood and check your blood sugar levels when you have not eaten. After that, you'll be made to drink this glucose drink, and then we take your blood an hour, 2 hours, and possibly 3 hours after that. If after 2 hours of drinking this glucose drink, your blood glucose level is 140 milligrams per deciliter or around 7.7 millimoles per liter or lower, then you are considered to be normal. If it is between 140 to 199 milligrams per deciliter or 7.8 to 11 millimoles per liter, then it indicates that you have pre-diabetes. If your blood glucose level after 2 hours is 200 milligrams or 11.1 millimoles or higher, then you have diabetes. So these three tests are able to help us to differentiate between diabetes, pre-diabetes, and someone who is normal. We have other tests, or you may have heard of random blood glucose test or random blood sugar test. This test you can take at any time, and you do not need to have fasted. So it just measures your blood sugar at the time that you are tested. And here, if your blood sugar level is above 200 milligrams per deciliter or 11.1, then it indicates that you have diabetes. But we cannot use the random blood sugar test to differentiate between pre-diabetes. It is because it only tests, we don't know. It only rules out diabetes, but we don't know whether you are pre-diabetic or you are normal. Similarly, some people may have heard of what we call the glucose screening test. Very similar to the glucose tolerance test, but for this, you do not need to fast. It is done just at the time that you visit the doctor. You'll be given this liquid that contains glucose to take, and then an hour later, we draw your blood and check the blood sugar level. If the result is 140 milligrams per deciliter or 7.7 or lower, then we say you are normal. If the result is, however, higher, then we will require you to now have this glucose tolerance test, where you first fast overnight and then withdraw your fasted blood sample and then give you this drink and repeat this test. So this is these are the tests that we normally use to diagnose diabetes.
Thanks, Dr. Nick, for a thorough explanation. Dr. Josephine, are you there?
Yes, I'm there.
Good. I'm just going to take you back with a question, and then I'll go to Dr. Anand. So, talking about the symptoms, or how does one know that they have diabetes? Would you suggest or recommend that people just randomly do fasting blood sugar test, or should they just go and check if they have diabetes? What is it? Because let's say you don't have a family with any diabetes history. Is it something that you would advise that people do?
Okay, so it's good to know. It's good to know your numbers, particularly as we grow older. The risk of developing diabetes increases. So for those who have, there are certain risk factors that definitely put others at a higher risk of developing diabetes than others. So for those people who need to, they will need to regularly check. But if you don't have any of those risk factors, the mere fact that you are growing means that the risk of developing diabetes can be high. And so such people need to be checked. So usually from the age of, say, 40, 45, it's recommended that you regularly check your blood glucose so that you can tell if you are developing diabetes or not. I hope it was clear.
Yes, it is very clear. Thank you very much. Thank you very much. So Dr. Anand, your question. So is every high blood sugar as a result of diabetes then? If you do a blood test and then the doctor says, oh, guess what? Today your blood sugar level was really high. Does it mean that straight away you are diabetic? You are muted, please.
So no, not necessarily. It doesn't mean that every high blood sugar condition that you have is a result of the disease process of diabetes per se. So we have some conditions that we call pseudo diabetic conditions. So that means other things can actually cause you to have a diabetic kind of condition or condition, disease process that kind of mimics diabetes. So for example, some medications have side effects, and those side effects can actually make you give you a bit of resistance in terms of how your body reacts to insulin, and so you get a buildup of glucose. So you have a buildup of sugar in your blood. So those kind of medications can give you a diabetic picture. You can get diabetic symptoms, and you find that when you have bloods taken, you'll be seen to have raised blood sugar. And usually what happens is, if it's identified that it's the medication that you're on, if that is stopped, then that those symptoms or that diabetic condition can be reversed. But in some instances, it can't. So, for example, some medications like what we call corticosteroids, which people take, for various reasons, actually primarily autoimmune conditions, people who are taking steroids for that, you can actually end up with diabetes. And it's not because it's a natural process. It's because of the side effects of the medication that you're taking. Some people that are on things like beta blockers, which are used, to treat your heart, that can also cause, diabetes via side effects. Some water tablets that people take can also result in you getting, diabetes as a side effect. So it's something that, if you know that you're on these type of medications and you are aware that you're getting some symptoms that look like diabetes, you could, go and, check with your physician and just say, can you have a look? It looks like I'm having this kind of, symptoms. Could it be a side effect of, my medication? And that can be reviewed and, you can be put on maybe different medicines that can help to reverse, you then going on to actually develop diabetes. Also, funny enough, there's a very popular diet. I don't know whether to call it a fad, but I know that it's very popular at the moment. People are doing it. It's called ketogenic diet, where people actually consume low carb meals to help to lose weight. And it's actually used in type 2 diabetics, to help them to lose weight, and has been known to reverse diabetes, for people that are put on that diet for a while. But funny enough, research is showing that if a person stays on a ketogenic diet for a long time, that lack of carbohydrates can actually end up tipping them the other way, where they actually become insensitive to the insulin that they're producing. So then you end up having a lot of glucose in your bloodstream. So kind of having sort of like a pseudo diabetic kind of picture. So that's something to also be aware of when it comes to, diets and things like that. And then the last thing that I'd like to mention is there's certain medical conditions that can also give you a diabetic, pseudo-diabetic condition. For example, pancreatitis, chronic pancreatitis has been known to, actually give, the people that suffer from chronic pancreatitis have been found to have a lot of glucose in their bloodstream. And so you find that if your acute pancreatitis is not well managed, and you go on to have chronic pancreatitis, you may actually end up having diabetic symptoms, and probably even go on to develop diabetes later on in the disease process. So yeah, so apart from the normal way of you developing diabetes, there are other things that can actually lead you to having a diabetic kind of condition, which can be reversed in some instances. In some instances it can't, and it can actually go on to being a proper diabetes medical disease.
Thanks for that, Dr. Annan. Does anyone have anything to add to that? If not, then Dr. Nick, my next question comes to you.
Okay, I'll just like to state that as Dr. Annan rightly said, a lot of these conditions can lead to diabetes. In fact, it's such that it's actually recognized as a fourth type of diabetes that's referred to as other types of diabetes. So most of the things she's listed are listed under that type of diabetes, other types of diabetes, where all these conditions can actually lead to diabetes in individuals who suffer from these conditions. So it's more like there's a secondary cause for that diabetes, whereas in the type 1 and the type 2, there's usually, we tend to say it's primary. There's usually not an underlying condition leading to that. So that's what I wanted to add to it.
Right, thank you. Just to double check, so does it mean that, like, if you are getting the high blood sugar as a result of medication, once you come off the medication, does it mean that your blood sugar level is going to return to normal?
In some instances, so for some people it can be reversed, for some individuals, it can end up being, so they might end up becoming diabetic and actually needing treatment for diabetes. So it depends on how quickly it's been discovered. So for example, in terms of medication, if you've been on this medication for and you've had, this diabetes there, and probably not have had, adverse, symptoms, or you probably asymptomatic, and then it's discovered later on that actually the medication that you've been on has led you to developing this condition, it might be too late for actually for your physician to actually have it reversed by stopping that medication. So it depends on when it's discovered, or when you present to your physician with symptoms and they're able to do something about it.
Right. Thanks for that elaborate answer. So, Dr. Nick, since prevention is better than cure, who is at risk of developing diabetes then?
Okay, thank you very much. So since we've spoken about 4 different types, or 3 main and 4 then pre-diabetes, let's start with type 1 diabetes. So for type 1 diabetes, the risk factors are not as clear as for the others. So we already said that it is thought of to be an autoimmune response, so your body mistakenly attacking its own cell. The known risk factors, however, include most of the things we can do nothing about. So a family history, so having a parent, a brother or a sister with type 1 diabetes is a risk factor for type 1. And age, we've said countless times that you can get type 1 diabetes at any age, but it is more likely to develop when you are a child or a teen or a young adult. And then we also see some relationship with race and ethnicity. For example, in the United States, we find more type 1 diabetes among the whites compared to African Americans or Hispanic and Latino Americans. So this is what you see for type 1. If you come to type 2, these same non-modifiable factors are there. So age, here Dr. Palu already mentioned the nice age of 45. So if you are 45 years or older, your risk of developing type 2 diabetes goes up. If you have a family history, that is having a parent, a brother or a sister with type 2 diabetes, that is also a risk factor. And then having an African, Hispanic, Latino or Indian heritage increases your risk of type 2. So whilst the whites have more type 1, the Africans and the Hispanic, Latino, Indians tend to have more type 2. But let's focus on the risk factors for type 2, which we can do something about. The modifiable risk factors are overweight and obesity. I had to take my time to say it because it is a growing pandemic. So if you are overweight, so we say you are overweight if you calculate what we call your body mass index. Very simple. We should all do it. All viewers should just take your weight in kilograms and then you divide it by your height squared, your height in meters squared. So for example, if you weigh 70 kilograms and you are 1.57 meters like myself, then your body mass index will come up to 22.9. So if your body mass index, just because I've asked them to do this exercise, if your body mass index is below 18.5, then you are actually underweight. Your nutritional status is underweight. We need to feed you some more. If it is between 18.5 all the way to 24.9, then you are normal. So if my body weight, my BMI was 22, then I'll be classified as normal. Unfortunately, it's not. If it is between 25 to 29.9, this is where we call you overweight, or with current classification by the WHO, pre-obesity. You are on your way to obesity. And obesity is then when your BMI is above 30. We also grade these to severe, serious obesity, so 30 to 35, and then some people have BMIs above 40. So what is important is that being even slightly overweight increases your risk of developing diabetes 5 times. And if you are seriously obese, then your risk of developing type 2 diabetes is 60 times. So obesity and overweight critical risk factors for developing type 2 diabetes. The next thing we need to watch is our current lifestyle. If you are physically active less than 3 times a week, and I'm not talking about only walking to the kitchen to get your food or walking to the dining table. If you are not doing some moderate to severe physical aerobic activity, 30 minutes vigorous walk, 3 times, at least 3 times a week, you are physically inactive. And that is a risk factor for developing diabetes. If you also have what we call pre-diabetes, if you already tested and your blood sugar is elevated above normal, but not as to the level of the diabetics, then you are still at risk of type 2. So pre-diabetes increases your risk to type 2 diabetes. Again, if you have been diagnosed with what we call a non-alcoholic fatty liver disease, it is a condition where your liver begins to store more fat. You know, your liver accumulates fat, so we call it, and it's not because of alcohol. We have liver diseases that are because of excessive alcohol. So this is non-alcoholic fatty liver disease. This may also increase your risk towards type 2 diabetes. And if you are a woman and you have also been diagnosed with gestational diabetes before, or if you've given birth to a baby that weighed around 9 pounds or 4.1 kilograms, then you are also at risk of type 2 diabetes. So these are the risk factors for type 2 diabetes. It remains very similar for pre-diabetes. So being above 45 years of age, having a family member with type 2 diabetes, being African, Hispanic, Asian origin, being overweight, and being physically inactive will increase your risk of developing pre-diabetes. And for gestational diabetes, we already said, if you have had gestational diabetes before in a previous pregnancy, then your risk of developing it again is there. So, or as I said, if you had given birth to a baby that weighed more than 9 pounds or more than 4.1 kilograms, or if you are overweight yourself as the mother, if you are more than 25 years old, if you have a family history of type 2 diabetes, or if you have this hormonal disorder, which we call polycystic ovarian syndrome. This is where little follicles form inside your ovaries. So this syndrome comes up with obesity, and often they also have insulin resistance. So if you are diagnosed with polycystic ovarian syndrome, your risk of developing gestational diabetes when you get pregnant is also high. And lastly, if you are African, Latino, Indian origin, then your risk of gestational diabetes is also elevated. So I hope you have put down some of the risk factors, but let's focus more on the ones that we can even modify.
Dr. Che, thank you very much. I'm going to ask you to repeat how to find the BMI, because you know, I've had conversations with people and people say, look at me, how can I be overweight? I only wear size this. I can't be overweight. So please, can you just re-emphasize how to, and I'm going to type it in because someone has also requested for that. So I'm going to type it in as well. So how do we find our BMI?
So I typed
and
it.
Does the number really matter irrespective of how you look in your own eye? So
okay, good. It's a very good question. So I think Prof. Lai has already typed it. So you measure your weight in kilograms. So if you live in the UK, please change the stones and the pounds to kilograms. Then it's easier for you. We also have tables for pounds and stones, but the classical one is to have your weight in kilograms, and then you measure your height in meters, and then you square it. If you're unable to square it, just give it to your kid at home. Now they are with the corona, with homeschooling, they will help you with it. So you just multiply your height twice. So if my height was 1.75, squaring it means 1.75 times 1.75. When you divide this, what you get is what is called a body mass index. And it is supposed to tell us the proportion of our body weight, which is fat. That is actually what it's measuring. So if the proportion of your body weight, which is fat, is more than 30%, then it is problematic. But it's good that you brought me back. Let me say that the BMI is only a guide. Another, what is even for diabetes in particular, what is even been shown to be more important is belly fat. So the fat, or what we call central obesity. So the fat that comes around your waist. So having a broad waistline is a great risk factor. It's even closer than using the BMI. So with that, we use the hip to waist to hip ratio, but we will not go into that. But just when you are developing this beer belly or this flaps, or I don't know how they call them, those things that we can hold. Yeah, the fat that comes around our belly, that is what we need to get rid of, because that actually represents or reflects fat around our organs, the visceral. So the BMI is a good guide, but if you also realize that your waist is become, your waistline has become so big, you need to work on it. It's very, very important. Yeah. So I hope you got it then. What?
I have. Thank you very much.
Yeah.
Okay. Thank you so much. So we'll move on to Dr. Anand. So why is it important to diagnose and treat diabetes early? In other words, are there any consequences for untreated diabetes or poorly treated diabetes?
Yes, so there is. Because actually you find that high blood sugar in your system actually affects quite a lot of organs in your body. So that's why it's very important to know whether you're diabetic and to have it checked out early rather than later. And also it's very important that once it's been diagnosed, that it is properly controlled. Because if you don't do that, the sugar that is circulating in your body can actually go on to affect, other organs. So you find that diabetic, diabetics have been found to be at higher risk of developing Alzheimer's. So if your diabetes is not properly controlled, is poorly controlled, or if it's diagnosed late, it can put you at high risk of developing Alzheimer's at an earlier age. So it's very important to make sure that you get diagnosed and treated early. It can also affect your eyes. So there's what we call retinopathy, which is basically where the sugar affects the little blood vessels in your eyes, and what happens is that they burst, and that gradually leads to blindness. So you find that a number of diabetics who don't have properly controlled diabetes do gradually end up having problems with their eyesight. Type 1 diabetics especially, you find that a lot of type 1 diabetics wear glasses because their eyesight with time starts to depreciate, and if your diabetes is really poorly controlled, you can actually end up being blind. Diabetes can also affect your heart. So the high sugar has been found to actually cause sort of like a hardening or a resistance of your arteries. And it also promotes the development of atheromas, or a disease process called atherosclerosis, which is basically a fatty kind of plaque that builds up in your arteries. And that can lead on to you having ischemic heart disease. So you end up having clots that develop in your arteries. So you find that diabetics are at high risk of having things like heart attacks, and they're at high risk of having stroke. And so hence why it has to be, managed really well, because once you become diabetic, your risk, goes up about 10 times of having ischemic heart disease. Diabetics can also have issues with their kidneys. The elevated glucose in the blood damages the kidneys and the filtering of your kidneys. So you find that if your diabetes is poorly controlled, you might actually end up having issues with your kidney. So diabetics can end up actually needing dialysis or even kidney transplant because there's been damage to their kidneys from the high sugar. Also, diabetics tend to have their immune system is also affected. So you're at high risk of getting infections. And even when you do get the infections, not only does it affect your diabetes. So you find a lot of diabetics, when they get chest infections or urine infections, they have to be admitted because your diabetes goes haywire. And also it's very hard for you to actually clear the infection. So your immune response is affected. It's slower and it's not as effective as it is. So it's very important for you to make sure that your diabetes is well controlled. And also, that's why if somebody is diabetic and they don't know that they're diabetic, they end up coming in. If it's women, you probably present with a thrush, or a urinary tract infection, or a wound that's not healing, or some kind of infection that's not getting better. You can also get your nervous system can also be affected. So you find that diabetics eventually they get what we call peripheral neuropathy, which is basically a numbing of your nerves, so your nerves become less sensitized. I know that I've in the past treated a number of patients that have come in, some with third-degree burns, because maybe they were cooking or they were doing something and their hand has been on the cooker, and they actually haven't felt the pain of the heat. And so by the time they discover it, they've actually had quite a bad burn on their fingers or wherever. So that's something that as a diabetic you need to be aware of. And here in the UK we have what we call diabetic nurse specialists. They actually look at all those things and try and monitor and make sure that your sensitivity in terms of your nerves is there, and if there's anything further that needs to be implemented to help to slow that down. But gradually your nervous system it does get affected, and the more poorly controlled your diabetes is, the worse effects you have. For men, when it comes to the nervous system, some men do present with erectile dysfunction. That can also be a problem with, symptom with their diabetes, and they can present with that kind of problem. And you find that if their diabetes is poorly controlled, that can be one of the things that, can majorly affect men. The other thing as well is the venous system is also affected in diabetes. So sometimes you will not have, patients tend to have what we call peripheral vascular disease. So they are not getting, the blood flow is not very good in terms of flowing, especially their legs. So they tend to develop ulcers, and the ulcers take a very long time to heal. And because of that, and combined with the poor nervous system, they end up needing to have, some of them, because the ulcers are not healing properly, they develop gangrene, which is basically a condition where their limbs are rotting, and they end up having to have amputation. Some actually have toes that actually come and they present and they're black, so it basically just dies, and it has to be amputated or cut off. So those are all effects of, poorly controlled diabetes, or, late, if it's a late diagnosed diabetes, some, patients can present like that with black toes or black fingers, that need to be amputated. I believe, it also affects your skin. Diabetes can also affect your skin because of the blood circulation, again, affecting wound healing. In pregnancy, it can cause miscarriages. It can also cause stillbirth for gestational diabetes. If it's poorly controlled, you find that women that are diabetic and it's poorly controlled can actually have a stillbirth, towards the end of their pregnancy. I know of, several women that, had gestational diabetes, and one lady actually 3 times had, stillbirths because of their poorly controlled diabetes. it can also affect your mood. So research has shown that diabetics are prone to getting depressed. So, you know, if it's poorly controlled, you know, and obviously if you're not well and you're getting, you know, all these other effects from it, it can actually lead to affecting your mood as well, and you becoming depressed. So I believe, you know, that's the main things that are affected by, you know, diabetes. I don't know whether anyone else has anything else to add.
So it sounds like, you know, this is a very serious condition because, as you talked about, it can affect every aspect of the body, and therefore, if someone has diabetes, I think it's very important that they get checked out and they have it well controlled. Is that what you would say?
Yes. So definitely, if you're diabetic, I would like to put. Actually, it's a good thing that you brought that up, Dr. Jonathan. It's very important for you to be compliant with the medication that you've been given or that has been prescribed to you by your doctor, and also to make sure that it is well controlled. And part of that control is making sure that you're going to your checkups and having your blood sugars checked, and also making sure that you're monitoring it yourself. So there's what we call a glucometer or a glucose meter, whereby you can actually do your own blood sugars to check to make sure that they're within the normal range. I'm sure one of my colleagues on this panel is going to talk about that, the testing part of your sugars. It's very, very important, especially for those that are type 1 diabetics. You know, because they're younger, they tend to be younger. Compliance is a problem. You know, teenagers and young adults are very difficult to encourage or to help when it comes to compliance with medication. But the thing is, with diabetes, it is quite a serious condition that even though you can live with it and, you know, have a normal life with it, you can only do that if it is well controlled and, you know, you're doing all the right things. If you're not doing the right things, it can actually shorten your life, you know, rather than you have it, you know, lengthened by doing the right things. So yes, by all means, you know, better control will lead you to, you know, a more normal, fulfilled life, and probably prevent all the things that we've talked about just now. Thank you.
Thanks, Dr. Annan. Hey, Auntie Kay, thanks for your comment. Dr. Akpalu, thanks for watching this program. Dr. Albert Akpalu, thanks for watching. Auntie Kay, thanks for watching. Joanne Asumeni, thanks for watching. Sama Brew, thanks for watching. And thanks for commenting and giving us some feedbacks. I have something here. I'm not sure whether it's a question. She says she got hers from giving birth to her second child. What do you think? Does it mean that she was pre-diabetic, or is this gestational diabetes?
So it sounds like it's gestational. So she got that, and then it kind of just as you know, progressed to being, you know, a chronic disease. That's what it sounds like from that comment. So it probably started from when you were pregnant, and then instead of it being reversing back to you having normal blood sugars after birth, it's kind of continued.
Right. So I'm going to ask a question based on that then. So does it mean that after giving birth, you have to do something for your blood sugar levels to reverse back to normal, or what do you have to do?
So normally what happens, so gestational diabetes is actually type 2 diabetes. So it's normally women that are either overweight when they get pregnant or put on a lot of weight when they're actually pregnant, that can go on to develop diabetes. Obviously, there's a genetic factor there as well. So if you do have a genetic, you know, like you've got first-degree relatives that have diabetes in the family, you are probably at risk of developing diabetes. So what normally happens after you've given birth, you are followed up. I don't know, this is what happened in the UK. So you will have a follow-up, you know, after giving birth to your baby, to see whether your blood sugar have actually, you know, returned back to normal, and your body starting to respond to the insulin as normal. But obviously for some women, that doesn't happen. They actually do go on to actually develop, you know, type 2 diabetes, and it never resolves back. And I think from the sound of that comment, it looks like that's what happened. You know, she got the diabetes when she, you know, got pregnant, and it's just never really resolved. But the good thing about type 2 diabetes is it's modifiable, you know, with your lifestyle, you know, obviously regular checkups, making sure that you're monitoring your, you know, your blood glucose, checking, diet, you know, losing weight if you have to lose weight, exercise, you know, all those things.
Right. Thank you, Dr. Anand. So talking about the complications, I'm just thinking, wow. Well, I personally know someone who's had a stillbirth because of gestational diabetes. I know someone who the legs had to be amputated. So how do we avoid these complications, Dr. Josephine? This question is for you. How do we avoid these complications that can result from diabetes? And the second question is, could diabetes be cured at all? Or once you are diagnosed with diabetes, that's it? There's nothing you can do about it.
Okay, thank you. So I would answer the second one first, then I'll move on. So when you talk about cure for diabetes, I mean, in general, I would say diabetes cannot be cured. But having said that, I also need to add that there's still lots of research, and there's evidence out there to suggest that diabetes, particularly those who have type 1 diabetes, they are looking out for ways in which that can be cured through certain medications that can modify or prevent this autoimmune process from taking place, so that your pancreas is not damaged. So lots of studies are going on in that regard, or finding ways of regenerating the cells, the pancreas cells, the cells that produce the insulin, or transplanting cells that produce insulin into patients with type 1 diabetes, such that they are able to make insulin on their own. If we are able to achieve that, then for those with type 1, we could say that there's a hope for cure for them. And for type 2, generally, there is no cure, although sometimes you come across terms like reversal of diabetes. So this usually happens for people who develop diabetes in the very early stages. They're diagnosed of having diabetes, particularly for people who are obese. If they're able to lose a lot of weight, significant weight loss, we could reverse their diabetes. That is, when they lose so much weight, it's mainly fat that they have lost, and it's the fat that makes the body resistant to the insulin, such that they can't respond properly to the insulin. So if you lose that weight, your body then tends to respond better to the insulin that the body is producing. Remember that those with type 2 have insulin in their bodies, just that it's not working properly. There are those who've had surgery because they are obese, surgery for weight loss surgery, and they also had diabetes, which has resulted in their diabetes actually going away. So, but the thing is, you need to maintain that weight loss. If you lose the weight, if your diabetes levels or your numbers come down, but you go and gain the weight, then the diabetes will come back. So that's what I would like to say about reversal or cure of diabetes. But what can we do to prevent these complications that Dr. Anand has elaborated for us? So when it comes to the management of diabetes, there are a few principles that can guide us as patients and as healthcare professionals to be able to manage the diabetes properly. It's very important that the patient who has diabetes is well educated, well motivated, After all, is a patient who has the disease, and the doctor can only guide them to manage the condition. They see the doctor maybe once every 3 months, once every 4 months. How long do they spend with the doctor in the consulting room or the healthcare professionals who help them to manage their diabetes? A few minutes, and they are back on their own at home. So the patient needs to be well educated. You cannot overemphasize that, because if they are not well educated, it becomes very difficult to manage their condition by themselves. And it's also difficult for doctors also to guide them to manage properly. So education of the patient is very important. You educate them the first time they are diagnosed. You educate them at regular intervals. So usually we tend to say every annual review, we have something we call annual review. Every time, once in a year, we try and go back and educate them. But the education is not like once, I've done once and that is it. It is a continuous process. Every opportunity you have, you use it to educate the patient, particularly for patients who may be going off target. You need to emphasize the points that make control good. Or somebody who has developed complications, it's an opportunity to re-emphasize or educate them all over again. So education is very important. The other thing is, of course, the patient has diabetes because the blood glucose is high. So that means we need to control the blood glucose. Dr. Anand kept saying the blood sugar is causing this in the body, the blood sugar is causing that. So it means that management of your blood glucose such that you achieve the target of management is very important. There's a, I think Dr. Che mentioned the glycated hemoglobin as one of the ways in which to diagnose patients. We can also use that in monitoring patients. So it's the, I was off during that time, so I'm not quite sure what he said, but it's a monitoring tool for diabetes. It's done every 3 months. It gives us an idea of your average blood sugar for the past 3 months, whether you have eaten or you have not eaten. It's a test that is done in the lab, and there are cutoff or target ranges for that. As much as possible, we try to individualize those targets. So we don't have one quote fits all. We are not going to say that somebody who is diagnosed today or somebody who's had diabetes for 20 years, is old, has all kinds of diseases, should have the same targets when it comes to control. So we tend to say that the control should be individualized. For those who are young, those who don't have other conditions, recently diagnosed, we tend to treat them such that we tightly control their blood glucose to prevent them from developing complications. For somebody who has 1, 2, 3 complications already, very old, has had diabetes 30 years or more, 20 years or more, we still want to control them, but not as tightly as somebody who has less complications. So the cutoff range, generally, we tend to say is 7%, okay, but or 53 millimole per mole. But it will vary, as I've said, can go lower or can go higher, depending on the patient you are dealing with. We don't only think of controlling sugar, we should also control their cholesterol and also control their blood pressure, because together, these three usually go hand in hand when it comes to complications, whether it's complications affecting the bigger vessels that go to the heart, to the legs, or to the brain, as was mentioned earlier, or smaller vessels that go to the eyes, to the kidneys, to the nerves. All these factors, risk factors, need to be controlled within the acceptable ranges that will be set on an individual basis. The other thing that we need to, the other ways in which we can monitor the blood glucose is the patient themselves monitoring it at home. You know, so you can have, Dr. Anna mentioned a glucose meter. Sometimes your doctor may tell you, you need to monitor your glucose at such and such a time throughout the day so that they can tell if there's any problem with your blood glucose or be able to adjust your medications for you to achieve your targets. There's also the continuous glucose monitoring. So there's a gadget that continuously can be measuring your blood glucose. All this is to make sure that your patient usually stays within the treatment targets most of the time. So that is getting good control or achieving your targets. We also want to, the main thing is I want to prevent these complications. So these complications, what we are really aiming for is to prevent them. If we cannot prevent them, at least we need to delay the onset of these complications. And it means adhering to all the advice that has been given to you, whether it's dietary, lifestyle changes, the medications, the screening for these complications. So usually when you visit your healthcare professional, they may take you through some examinations to be able to see whether you've started developing these complications. You may want to examine your feet to see whether you have any complications, your eyes or your blood vessels, the pulses and all that, just to make sure that we identify these complications for those who we are not able to prevent the complications from occurring. And then beyond that, frequently, so usually we say an annual review for those in which after every clinic, every visit, you don't find anything. Once a year at least, you need to do the examinations as well as blood tests to ensure that they are not developing the complications. And depending on what you find, the monitoring can be more frequent, or you still stick to once a year. Another principle is to ensure the quality of life of our patients or the psychological well-being of our patients. Sometimes we tend to forget about that aspect of management. It's very, very important because our patients are going through lots of stress, lots of anxiety, some develop depression and all kinds of mental illnesses, which if we don't tackle, is going to worsen their control and can lead them to developing these complications that I have listed. But how do we go about doing these things? So we have ways in which it has to do with our lifestyle. That would include the diet that we eat, exercise, I believe as mentioned earlier. So we need to engage in physical activity. Most of the time we want to say your leisure time physical activity. So that is what we aim at. But for those maybe their schedule is so tight, they don't have time to exercise, then you have to incorporate the physical activity into your daily schedule and try and minimize your sedentary time, sitting down at one place. If you can't do the exercise recommendation, which is at least 30 minutes a day for at least 5 days in the week for an adult, then try and incorporate a lot of activity into your schedule for the day. Walk around. If you go to work, you can climb the stairs rather than using the lift. If you are using the bus, don't stop immediately very close to your house. You can stop some blocks away from your house so that you can walk home and all that. All that can improve your insulin resistance, in that it helps you to lose weight and then improves your insulin resistance and therefore can help with control. For type 1 diabetes, of course, weight loss is very important. We've mentioned that as well. So that's one of the things. And if you lose about 5% of your weight as a patient with diabetes, it's very helpful in terms of, or clinically significant in terms of improving your control. And when it comes to medication, for those who have type 1, we already know they don't have insulin. And so what we need to give them is insulin. And there are various regimes that we use to treat those who have the insulin regimes we use to treat type 1 diabetes. For type 2, usually we'll start with tablets. And there are various types of tablets and various, I should say, reasons why we give certain tablets. But I'm sure most of us would know of the drug called metformin. So generally, or by and large, the recommendation is that the first drug of choice for somebody who has type 2 diabetes is metformin. And then if it's not adequate as a single therapy, then we may need to add on other treatments as we go along. And what you add on depends on your patient. It's individualized. Some patients, because of some comorbidities or complications they have, you have to choose a particular kind of drug to improve those complications. Sometimes we look at cost. If the drugs are expensive, you want to go for a drug that is a little cheaper so that your patient can afford to buy and take the medication. Or you look at the side effects of the drugs. For some patients, they cannot take certain drugs because of the side effects that the drugs may have, which are not desirable in that particular patient. Things like weight gain. If it's a drug that's going to cause the patient to gain weight and the patient is already obese, you would not want to select that drug for that patient. So these are the pharmacological or the drugs and the non-drug ways in which we can manage our patient. But to end it, I would want to say that when it comes to the management of diabetes, it's a multidisciplinary team affair. One doctor cannot take all the responsibility. Okay, so we have different groups of health professionals who come together to ensure that our patients' management is well done. And as part of that team, the patient is actually part of that team. The patient is actually the center of that team. And so each member of that team aim is just to make sure that this patient is able to achieve the aims or the aims of management so as to prevent these complications. So there are various healthcare professionals from endocrinologists, diabetologists, psychologists, dietitian, podiatrists, neurologists, nephrologists, all these different disciplines need to come together to ensure that our patients are well managed. Thank you.
Thank you, Dr. Josephine Akpalu. What I liked most was that irrespective of the fact that you have lots of people coming together to manage diabetes, the patient, him or herself, should be at the center of it. So you can't just think that, oh, today I'm going to see the doctor, and then when you come back home, go back to all your old habits and everything and still expect the doctor to work a magic for you. Right, thank you. Professor Lai, over to you.
So Dr. Anand, so we've talked about the negative effects of having high blood sugar, and all the discussions we've had around diabetes has centered around, controlling your blood sugar, it not being too high because of all the effects on the body. Is there such a thing as low blood sugar? Can we control it too much? Can it become low? And if so, does it have any bad effects?
Yes, thank you, Dr. Jonathan. Yeah, so there is a condition whereby you can have low blood sugar. There's a condition that we call hypoglycemia, which literally is, meaning that you have low sugar in your body. And this is quite common in diabetics, especially those that are on insulin. You find that it's a condition that happens to type 1 diabetics if their insulin is too high, or they're probably not managing their diabetes well, in terms of they're not eating enough. So hypoglycemia or low blood sugar can be a medical emergency when it comes to diabetics. In terms of if it's not treated within a given time, it can lead to complications, which can be convulsions, and maybe even have a patient go into coma and probably even die if it's not attended to in a reasonable time. So apart from diabetics having low blood sugar, hypoglycemia can also be seen in other conditions as well that are not necessarily diabetes. So you get some people getting hypoglycemia in critical illness. For example, somebody who's very ill. Some people that are probably have a bad reaction to carbohydrates. For some people, it can be a side effect to medicines that can also affect, the amount of glucose that they have in their bloodstream. They can also have that condition called hypoglycemia. In the UK, low blood sugar is measured when you have a blood sugar that is less than 4 millimoles in your blood. So once it goes below 4, then you are termed as hypoglycemic. It can go from being mild to severe. So your symptoms depend on what stage your hypoglycemia is. For diabetics, you find that if either they haven't eaten enough, they can get hypoglycemic. If maybe they've eaten but have been, engaged in a lot of activity or are doing, vigorous exercise, that can make them hypoglycemic. For some who probably go out and binge drink, they can actually end up being hypoglycemic as well. We also find that people that have pancreatic cancer can that actually affects their insulin producing cells. So they start producing a lot of insulin. They can also present with hypoglycemia where they have very low blood sugar. In terms of the symptoms of hypoglycemia, you find that people, I'm talking about diabetics now, if you're a diabetic and you're on insulin and you start getting low blood sugar, you can start sweating profusely, and some become hungry. You start feeling very hungry, you want to eat, and other people become confused. So, disorientated, you don't really know where you are, you're talking gibberish. So the people around you need to know these symptoms if you're an insulin taking diabetic. So once you start acting a bit strange, or some people become very quiet and they're sweating and probably breathing a bit heavy, and probably having some palpitations. If you have people around you and they know these symptoms, the best thing that they can do is to quickly give you maybe a sweet or candy, depending where you are, or maybe a teaspoon of sugar. For some people, there's what do you call it, a sugar injection that you can be given that can quickly, get you back, to feeling a bit normal so that you can eat. You can also give them like a sugar drink just at that time when they're having those symptoms. For those that are actually have sudden convulsing and going into a coma, it's a medical emergency. So you need to get them into hospital, because for some hypoglycemic conditions, you can't actually reverse it just by giving them, a sugary drink or a teaspoon of sugar. They might actually need what we call intravenous sugar, which is put into their system, via, their blood. So that's, what we, I can explain to you in terms of hypoglycemia. It's something that I believe that diabetics need to be very much aware of, especially if you're taking insulin, and make sure that the people around you are aware of as well. We normally encourage, our insulin taking diabetics to always make sure that they have some kind of snack, in their bag, to take along with themselves, so that if they're starting to feel, that, because you will be aware that, you kind of is starting to feel a bit shaky, a bit giddy, so once you start having those symptoms, you can take a fruit or a banana or something just to make you, feel better enough for you to have your meals. The other thing as well is that diabetics, you can't skip meals if you're an insulin taking diabetic. You have to make sure that you're having your meals at the right time. So your breakfast, lunch, and dinner, and also snacks. If you can take some healthy snacks in between, you have to do that. And if your insulin, if you find that you're getting hypoglycemic or low blood sugar often, then you need to let your physician know about it, so that at least they can look into your insulin and see how they can adjust it for you. Because it's not every insulin dose that may be agreeable, with you, or, that you're prescribed. There are different kinds of insulins out there that can be prescribed to individuals. So you need to find what is agreeable with you, and what will give you better control with your blood sugars. I hope that answers the question. Thank you.
Yeah, it does. Thanks so much, Dr. Annan. Our time is fast spent, but we are just going to push and finish off as quickly as we can. Dr. Josephine Palu. So talking about hypoglycemia, does it mean that diabetics cannot fast then? Because like from what you've said, as you grow up, maybe you're more at risk of developing diabetes. And actually, there are so many older people who have diabetes. Does it mean that they cannot fast and that's it? Or is there a way they could go about fasting, knowing that they cannot be skipping meals like Dr. Annan said?
Yeah, thank you. Yeah, so patients who have diabetes, yes, they can fast, but it is not recommended for all patients who have diabetes. Not all patients who have diabetes can fast. Some can and some cannot. We usually fast for religious reasons. For the Muslims, they are aware of this fact. So in fact, they have categories of people who are exempted from fasting. And it's well known to the Muslims. But yet you have people who may be exempted, but yet still will want to fast. As I said, it's not everybody who is allowed to fast or who can fast safely. Okay, so for patients who have diabetes, we need to examine them, evaluate them, and be able to place them in categories of those who are at high risk of developing problems or complications if they should fast, as against those who have a very low risk of developing complications. So depending on where you fall, your doctor would advise you that you have a very high risk. If you fast, you may develop some complications. So what the complications we are talking about are the hypoglycemia that we've just talked about, or the low glucose level. Another complication that can happen with fasting is the other way, that is high blood glucose. If you fast, you can either get low blood glucose or get high blood glucose. For the Muslim fast, they are also supposed to stay away from drinking water or fluids. And so another complication that can occur is dehydration. You can become dehydrated. They can become dehydrated. And so based on the risk factors that you have, so usually if you have poorly controlled diabetes, usually will not be advised to fast. Or if you have diabetes and you've developed some complications, it will not be wise for you to fast because your risk of complications, developing these hypoglycemia, high sugar levels, dehydration. In fact, the high sugar levels sometimes, particularly for those who have type 1 diabetes, can go to the extent that you can have an acute complication that can send you to the emergency room. The complication we call diabetes ketoacidosis. It's in situations where you don't have enough insulin, your blood glucose level is very high, you have a lot of acid in your blood, and sometimes can lead to death. And so if you have type 1 poor control, diabetes, if you have complications, kidney disease, heart disease, usually would say it's not advisable for you to fast. But for those who want to fast, it's important that they make it clear to their healthcare professionals that, particularly with the Muslims, they know when they are going to fast. So before the time, they need to let their health professionals know so that they are well evaluated. If they are not in good control, they have to be in good control a month or two even before the fasting period starts. And during the fasting period, sometimes you may actually have to change the medications the patient is on so as to prevent these complications. During the fasting period, the doctor may change either your medication or change the timing of your medication or the dose of the medication. You may sometimes want to switch the doses around, particularly for those on insulin. They may want to give them the higher doses in the evening rather than in the morning. And then also advise the patient to be monitoring their sugar more frequently, so that if they notice that during the fast, their blood sugars are dropping, anything that drops below 4 is an indication that they need to stop the fast. Or if they are monitoring and their blood glucose levels goes very high, anything that goes above 16, they are advised to stop the fast. And so these are in a nutshell, there's a lot that goes into it, but just to briefly talk about diabetes and fast, these are some of the things that can be done for patients who want to fast if they have diabetes.
Thank you very much, Dr. Akpalu. So, Dr. Che, how can one prevent? So we talked about the people who are at risk for developing diabetes earlier on. So let's say someone has either a family history, or they are obese, or they have some of the other risk factors that we discussed earlier. How can one either prevent or delay themselves from getting diabetes, especially if they have these risk factors that you've talked about?
Okay, thank you, Dr. Lai. So we'll take them again in 3 parts as we learn them. So for type 1, type 2, and gestational diabetes. Type 1 diabetes is very simple. Currently, no one knows how to prevent type 1 diabetes. If you remember, the risk factors we spoke about are non-modifiable. We are still investigating the environmental reasons of why your body's immune system goes mad and starts attacking its own cells. But for now, no one knows how to prevent type 1 diabetes. So let's go to type 2 diabetes. For type 2 diabetes, we can prevent and delay it with simple lifestyle changes, such as losing weight if we are overweight. Very, very important. Weight loss, I think Dr. Akpalu already mentioned it. It's also key in management of those who even have diabetes. She mentioned losing 5 to 7% of body weight, very, very key to reversal. So weight loss if we are overweight. So it's good that the viewers were interested in the BMI and they've calculated them. So if you are overweight, make sure you take steps to lose weight. And this includes increasing or being physically active. Dr. Akpalu also mentioned it, that there is no excuse. We all have 24 hours. Even if we are busy, we need to squeeze it into our normal routine, doing at least 30 minutes to 45 minutes of moderate intensity activity on most days. I mean, research says up to 150 minutes. So if you do 30 minutes, then you're doing Monday to Friday. If you don't have the time and you want to do 3 days, then probably 45 minutes to 50. But this is based on your age, based on other conditions you have, your ability. Fitness is not obtained in 1 day, so don't overexert yourself. It's about continuity, doing something that you can continue. 30 minutes vigorous walk, little activities. Drive at all costs. Probably you may want to park your vehicle a little further away from your office so that you can walk, so not to park right in front of your office door. Some people may even want to park right into their office. So let's change these activities that make us physically active. The next is eating a healthy diet, avoiding too much sugar, saturated fats, and last on these lifestyle changes is cutting or avoiding tobacco use. Tobacco use or smoking increases the risk of diabetes and cardiovascular diseases. And I'm sure Dr. Albert Akpalu is listening and will be happy that I say this again. So cut out tobacco use, smoking totally out. And someone may say that we've heard these things over and over. Everyone says it. These lifestyle changes or modifications we are talking about are evidence-based. All right. So research studies have found that if you go on these structured lifestyle modifications, you are able to cut your risk of diabetes, developing type 2 diabetes, into half. Indeed, in a study in the United States, the Diabetes Prevention Program, such lifestyle changes was able to reduce the risk by 58% over 3 years. So let's not take it as a joke. If you just be physically active, eat healthy, lose weight, and in a structured manner, not adding it to your New Year resolution and doing it for January and then we forget about it until you don't fit in your clothes again. Then you will remember and we'll go back to it. Structured lifestyle changes, very, very important. The next thing that there's evidence for in terms of preventing and delaying diabetes apart from the lifestyle changes that I said, there are some certain medications. Dr. Apalu also mentioned metformin. So metformin and another medication, acarbose, which so metformin basically inhibits your liver from producing more glucose to worsen up the problem of high glucose in your body, and acarbose then inhibits the carbohydrate that we eat that is converted into glucose from being absorbed. So they just don't want to worsen the situation. These two drugs, for example, have been shown in clinical studies to be able to reduce the risk of developing type 2 diabetes in certain groups of populations. So it's not for all. So for example, the metformin group works better for people, for younger people that were obese, so between 25 to 40 years, that were overweight. It works better than when you are older. So it's not for all groups, but these are opportunities or medication that help. So once you have that visit with your physician, he or she is going to look at your risk factors as we've discussed them. Probably you may even need some of these other medications for other purposes, and then they give them to you. I am not prescribing that everybody goes to the pharmacy to go and buy metformin or acarbose or whatever. That's why I'm emphasizing that it is not for all people. There are certain groups of people that they benefit from, and these medications have side effects. Some may not tolerate it, so please do not go and buy them. This is only for information, because I saw a comment that they praying that God gives the doctors to get medications for diabetes, and Dr. Apalu was reminding us that we have a lot already. So just to know that there are things there, but the best thing is that there's a saying that if you don't eat your food as your medicine, you eat a lot of medicine as food. So God has already given us the food. Let's eat healthy, and that will help. For gestational diabetes, the main prevention is before you get pregnant. You may be able to prevent it by losing weight if you're overweight, and then trying to eat healthy. Let's make it a habit of eating healthy and getting into regular physical activity. If you do that before you get into pregnancy, I think that it reduces or delays the risk of gestational diabetes. So in the interest of time, I think we'll end it over there, unless there is more that you want me to add.
No, I'm happy with that, Dr. Che. Thank you. So finally, this is a bit I am really interested in, Dr. Che, and I'm going to come back to you. So you were talking a bit about diet, and I also had a question coming from Auntie Kay. She's the godmother of my older girls, and yes, she was also asking about reducing the intake of carbs. So I'm going to read a few things out to you, and it's all about the diet. So one, I've heard that cinnamon reduces diabetes or cures diabetes. Secondly, if you are diabetic, you have to eat a restricted diet. Thirdly, you shouldn't be eating sugar. Fourthly, you should avoid carbs. Right. Based on all these things, could you please advise us on how to have a healthy diet if you are pre-diabetic or diabetic?
Okay. All right. So as Dr. Apalu already told us, unfortunately, we do not have a cure for diabetes. So it cannot be true that cinnamon will cure diabetes. It doesn't. Yeah. All these medications or local stuff that help build immunity or give us vitamins are all good, but they do not cure diabetes. What we need to watch, as she told us in treatment, is that diet cannot be taken out of the treatment package, all right? But when we are looking at a diet for a diabetic, we are looking at, it should be a diet that aims at weight control. So here the emphasis is on low calories, not necessarily carbohydrate. I'll speak about that. And then that diet should also be providing nutritional requirement. So not cutting out things which we need. So making sure that you have vegetables, you have fruits, you have nuts, you have whole. So it must provide nutritional requirement. And the diet that we also take must be able to allow good glycemic control, as Dr. Apalu was talking about. And also this diet must be able to correct any associated risk factors like cholesterol and what have you. So there is a whole, that's what she mentioned, that we have a whole team of people, dietitians, that will sit with you and the diet that is formed for someone is individualized. So it is not like we adapt an Atkins diet or a South Beach diet or a keto diet. It is individualized. So the dietitian will go through with you, and based on your own body lipids and your cholesterol and your hypertension and other risk factors, we come up with this diet. Okay, and in general, I don't know where this idea comes from, but the diabetics eat everything. It is just the quantities. So it's the calories that we reduce. So the recommendation is that they still take carbohydrates. For diabetics, carbohydrates provide up to 50 to 60% of the total caloric intake. It's just that the carbohydrate they take is the complex and high fiber carbohydrate, not the polished stuff. So it is the type of carbohydrate you are taking which is important, right? And then about 20 to 35% of their calories will then come from fat, and then protein form about 10 to 15%. All right, and this diet must avoid excess salt. So salt out of the diet totally. So this is speaking about the diet of a diabetic. But because a lot of us, as we had 372 million people in 2019 alone had pre-diabetes, we are on our way. So the general recommendation for a healthy diet for the general population, for all of us listening, if it is like a take-home message from the International Diabetes Federation, is that we should choose water, tea, or coffee over fruit juice, Coca-Cola, or soda, or any of the sugar-sweetened beverages. So let's drink our tea. That's what I'll drink. I'm sure those in the UK have no problem with tea. Tea, they will drown you with tea. So it is better to drink your tea, coffee, or water than to take juice and soda and all these sweetened beverages. And at least we should eat 3 servings of vegetables a day, including green leafy vegetables. I still have a vision of the picture that Albert Apalu showed with all the contombre and everything, trying to tease those of us living elsewhere. So with a lot of greens in there, and then eating up to 3 servings of fresh fruits every day. And when we want to snack, let's choose the nuts, a piece of fresh fruit, unsweetened yogurt, instead of all the unhealthy pizzas and the fast foods. So let's change them into these healthy options. Let's limit or totally cut out alcohol. And if we are taking in the protein, let's look for the lean cut and white meat like poultry, seafood, instead of the red and the processed meat. Okay, and let's choose peanut butter against chocolate spread and jam. I know we all enjoy them when we're young, but we have become more aware. Let's choose these healthier spreads like peanut butter instead of going with chocolate spread and jam. And let's go for the whole grain bread, rice, and pasta instead of white bread, rice, and pasta. And I think that also staying with some of the healthy unsaturated fats like olive oil, canola, corn flour, sunflower will be very helpful for us. So this should be the take-home message on diet for all of us and for the diabetics. Thank you.
Thank you so much, Dr. Che. Thank you so much for that. I have a quick question here. I don't know if someone would like to answer it, and then I'll come to Dr. Josephine Apalu for you to give us a take-home message, and then Dr. Anand, and then Professor Layu will just end us off. So does anyone want to answer the question about okra, whether it controls diabetes, please?
Yeah, we see, if you ask a group of physicians to answer these questions, we want evidence. You know, as Dr. Bamia will say, you and I were not there. We haven't seen yet any studies talking about okra reducing diabetes. The idea is that all these fruit, vegetables and the greens and what have you, they are better. They all produce and help us in our total health. So it's not like it is reducing or controlling diabetes. There are other plants or things which help reduce blood glucose. But for okra, it is a nice fruit or something to eat. But I have not seen any evidence that it is treatment or cures diabetes. And the idea is that we are not looking for the, what do you call it, the silver bullet or this thing that fits it all. Then all of us go and drink, take it. Like, once we say if you inhale hot water, then everybody, if you say neem tree, then everyone. What we are saying is have a balanced diet, have 3 servings of vegetables, including okra, including other things, and that will be good. Yeah.
Awesome, thank you. Dr. Palu, what's your take-home message for us, please?
Okay, thank you very much. Well, what I would like to say is that, I mean, we all know this saying that prevention is better than cure. And so when it comes to diabetes, I think what we need to bear in mind all the time is that it's a condition that we can prevent, particularly the type 2 diabetes. And so we need to take into consideration all the advice we have received this afternoon regarding our lifestyle so that we can prevent diabetes. But for those who have already developed diabetes, it's important that we adhere to the management principles that we know or we've heard of today. It's also important that we are empowered, we are well educated, well motivated to be able to take control of their condition, because it can be controlled. As much as possible, let's always be ready to know. For those who don't have diabetes, always be in a situation where you always want to make sure that your levels or your blood glucose levels, in addition to blood pressure, cholesterol, and all those things, we test them as often as is requested by a healthcare professional, so that we can catch these things early and do something about them. Thank you very much.
Thank you, Dr. Palu. Dr. Anand.
Thank you. So my take-home message is education is power. Just keep educating yourself. And like what Colin said, you know, it's important to make sure that your diabetes, if you're diabetic, is well controlled, and you know, modifying all the things that have been mentioned tonight for type 2 diabetics. And also to bear in mind that, you know, you can actually lead a normal life. You know, it's a chronic disease, but you can actually have a good, you know, normal life if you are able to control, you know, the disease process and to manage your diabetes well. And in terms of eating, yes, you can eat everything, but please bear in mind that, you know, if you've got diabetes, you have to stay away from sugar. I've seen quite a number of diabetics that, you know, when they get to places where there's parties, they're eating cakes, they're eating, you know, all the sugary stuff that everyone else is eating. And that sugar will, you know, lead to your diabetes being poorly controlled. So, you know, enjoy your food, you know, eat all the healthy food groups, but do stay away from things that have got sugar in them. Here in the UK, there's some sugar substitutes that you can use. So if you're someone who's struggling with your sweet tooth, you know, and you know, you want something sweet in your, you know, in your mouth or on your palate, you know, look for other alternative things to use, you know, to supplement, you know, the sugar that you're missing in your food. Yeah, but yeah, thank you. Thank you very much.
Thank you, Dr. Anand. Professor Layu, what do you want to just be the icing on top of our cake? What do you have to say to us before we sign out?
So I think, you know, over the last year, we've been having these sessions, and, you know, the first few times we talked about preventive health, and one of the take-home messages that we gave was that, you know, as we grow older, we need to know our numbers. And I think Dr. Palu kind of alluded to that today. You know what your blood pressure is, know what your blood, you know, sugar is, your fasting blood sugar is. I mean, and then your cholesterol level. And if it's high, then you need to do something about it. And these are things that you're going to know, you know, if you're going for, you know, in some parts of the world, I know we don't have the preventive health practices where you go for an annual wellness check, right? but it's important for us to do that as you get older. You go for annual wellness check, and as part of that, you're going to have your cholesterol checked, your blood pressure checked, and then obviously your height too. So you get your BMI calculated at that visit, and then knowing what your blood sugar is and all that. This helps us to know when we are kind of at risk of developing diabetes, for example, at risk of developing, cardiovascular disease. And we had a session on that as well, and talked about stroke and all that. And so knowing our numbers is very important. And once we know, once you're educated, you can do something about it. And all the things that we've talked about, prevention, we are going to be able to do this. If I should just use a few seconds to maybe make it easier for people to understand the difference between type 1 and type 2 diabetes, right? So let's assume that there's a river, okay, and there's no bridge, and you have to get some goods from one side to the other, right? So, and you have a pontoon or a boat that is going to carry the goods from one bank to the other. So in this case, the goods that you want to carry to the other side is the sugar, okay, or glucose. Now, when you eat your glucose, the glucose is in your bloodstream. It has to get into the cells so that it can be used. So akin to transporting them across the river to the other side. So in type 1, there's no carrier. The insulin is what pushes the glucose into the cells. So like the pontoon or the boat, you don't have the boat. The boat is not there. So now your goods are piling up at the other bank, and it's causing problems, right? In type 2, the boat is there, but it can't carry the goods, and so that is for people who did not understand the difference. It's like you have the insulin, but the insulin is not able to carry the glucose into the cells. So that is just a little analogy to help people kind of picture what we are talking about when we're talking about the difference between type 1 and type 2. Thank you.
Nice analogy.
I love that analogy too. Yeah. Awesome. Thank you so much. Yeah. Right. So that's the end of tonight's program. I believe you've learned so much. I have learned so much myself, especially in relation to gestational diabetes. It was something I knew a bit about, but I think, I know much more about it today, and I'm happy about it. And thanks so much for making time with us, Dr. Josephine Apalu, Dr. Patience Anand, Dr. Nick Che. It's quite late at your place now, but thanks for making time. And again, our honored Professor Lai, thank you. I'm just going to end with an advert, and we'll see you all next week at 8 p.m. UK time. Thank you.
And we thank our viewers for their comments and for their feedback.
Absolutely. Without the viewers, there's no need for us to do this. So thank you, viewers, for staying tuned with us. Thank you.
Thank you.
Since its foundation, Global Wisdom Academy's vision has been wisdom-centered, wisdom-focused, and wisdom-driven. We are partnering with Oral Roberts University's Bible Institute, whose central vision has been the mandate God gave to Oral Roberts